And good morning. It is November 7th, 2023. I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute. Our patient today is having cervical spine herniated disc problems, C5-C7, and we're going to be going in endoscopically to repair those two discs. The alternative surgery would have been a fusion, ACDF. ACDF surgery is highly invasive, makes a big incision, lots of scar tissue, trauma to the muscles underneath the skin, and you have to have a metal plate bolted to your spine, basically. You lose movement forever, and people have trouble swallowing. There's all kinds of complications that occur. ACDF surgery has a complication rate of 48%. It was just published this year. And Deuk laser disc repair in the cervical spine has a complication rate of 0%. So it's very safe to do endoscopic surgery. Plus, we're not putting a metal plate. We're not fusing the spine. We're not even going to open everything up like you would with an ACDF. We're just going to go in through a 4mm incision. And that's what we're doing today. Our patient has already had the Deuk plasma rhizotomy done on the back. We did that first. That's the first video for today. Now we're going to do his disc repair. Now, the first thing we'll do is use the X-ray machine to find the two discs we need to repair. And those are going to be the number 5, 6, and 6, 7. Everybody agrees? Yes. So let's count, Jordan, on that X-ray machine. There's number 2. Can you see that, Sanjay? The white arrow?
Yes, I do.
2, 3, 4, 5, 6, 7. So those bottom two discs are what we're targeting. Let's get started. Our patient is completely asleep, and of course he has a muscle relaxer on board. Now he is from Brooklyn, New York. He traveled to Florida to have his neck fixed. He did not want fusion. Shot? All right, 2, 3, 4, 5, 6, 7. I'm right over 6. Everyone agree? So we'll go down to 6, 7 shot. Looks good. AP. I'm going to use both AP and lateral X-rays to navigate. Perfect. Lateral. So we're directly over the center of the spine and the disc. That's where we want to be, center. And I slipped up a little north. Shot. 2, 3, 4, 5, 6, 7. Perfect. So we're right where we want to be. AP, I'm right at the front of the disc. I want to verify that on the AP view. Shot quick. That's perfect, right in the center. Now lateral. So I'm going to enter the front of the disc with this needle. Shot. Very nice. And I'm going to stay there, and I'm going to advance my needle. Shot. Perfect. We're going to do what's called a discogram. That's where I will inject a dye into the disc, and the dye has several components. One of them is our Deuk Spine Blue dye shot. You want to make sure you watch the tip of the needle. It doesn't advance into the spinal canal. There it is. Let me give a little bit more. Shot. Perfect. You can see the tear in the back of the disc, and the tear is low. Yep. And it's leaking dye into the spinal canal. Just verify our levels. 2. Go ahead with the arrow. 2, 3, 4, 5, 6, 7. Everyone agrees we're at 6, 7. Next, I'll introduce the guide wire through the needle. And then I'm going to make my incision. Before I do that, I'll put some numbing medicine. Our incision will be 4 millimeters. That's all we need in order to introduce the dilator and the tube that we do the whole surgery with, 4 millimeters. So with this type of surgery, there's really no scar tissue. There's no real bleeding. There's just a tiny bit. By the time we're done, there'll probably be 20 drops of blood. All right, shot. You want to keep an eye on your guide wire. You do not want the guide wire moving deep. Shot. So you always want to take pictures while you're doing this. just to watch it. Shot. You can see the guide wire there in the disc. I'm taking the needle out. Shot. Perfect. Once I have the needle off the guide wire, and you got to be careful because the needle will literally pull your guide wire backwards. All right, I'm verifying my level one more time. 2, 3, 4, 5, 6, 7. Now I will go over this guide wire with the dilator. The dilator is about 2.5 millimeters wide, maybe 3 millimeters. Huh? You're fine, yeah. We're good. You don't need to do anything. His neck is nice and long and skinny. Shot. It's the perfect neck for doing neck surgery. All right, shot. Now, you have a marking pen? Shot. Perfect. Let me have the marking pen. All right. Hold on. Take that. You guys, if we were doing an ACDF surgery, this would be the incision, okay? There's two ways to do the incision. One of them is like this. We call it horizontal. The other one is oblique. I would not normally do an oblique incision on a 2-level ACDF. I don't know many doctors that would. Most of us would do horizontal. But you can see the difference. Take a look at this, Sanjay. 5 millimeters versus 35 millimeters. Okay? This is going to cause scar tissue, bleeding, damage to all the muscles, soft tissues in the neck. That's why the complication rate is so high. All right, let's get an AP. Let me have that. I want to make sure that we're in the middle of the spine. If you do endoscopic anterior cervical surgery, you have to be checking AP and lateral views, minimum of 2 views. That's really nice, actually. Show us the middle of the spine, Jordan, on that x-ray. You guys see the spinous process? That's it. We're right there. We're about 4 millimeters to the left, which is fine. You can be about a centimeter off of the midline, which is 10 millimeters. No problem. All right, so now I'm going to advance this dilator through the annulus anteriorly. This is the front of the disc. Shot. Now remember, the dilator itself is not cutting, it's spreading. There's nothing cutting on the dilator. If you look at the surface, come on, the dilator does not have a cutting surface. The dilator has a spreading surface, kind of like a giant pin that you put in your lapel. Everybody knows what I'm talking about when you put a pin into your lapel on your jacket or your dress. It doesn't cut your fibers, it spreads them. All right, now we're going to do the entire surgery through this little tube. Okay, you guys see this, Sanjay? This tube is the whole surgery through. It looks like a coffee straw. It goes over the dilator, slides down through the 5 millimeter incision. I was a little heavy-handed. Instead of 4 millimeters, I made a 5 millimeter incision. All right, we're going to fix 2 discs with this one incision. You can see the tube is kind of at the front of the spine. Now I'm going to, I don't think it's going to, okay, can you move that please? Should be pretty easy. You got to keep an eye on the dilator. You do not want it going into the spinal canal. You could paralyze the patient. So you want to slide the tube right over the dilator to the back of the disc. That's pretty much where we are, but I want to move it back a little bit more. I'm not entirely happy. Shot. So I'm going to bring my dilator in a little bit more. Perfect. And now I'm going to slide my tube over the dilator. Shot. And I could feel the tube is now anchored at the back of the disc. There's little bone spurs back there. Any questions so far from our audience?
No questions.
would you show the video on why a herniated disc in the neck causes pain? And by the way, take a good look at this. The whole surgery on his neck, and what a beautiful neck. Okay, let's have a wet Raytech. Sanjay, this will be a great picture for the website, for the cervical DLDR.
Yes.
Okay, let me clean up some of this stuff. This is iodine material that we put on the neck to prepare the skin. But you can see how small the incision is. Let's have a ruler. Okay, and it's bloodless. We had about 5 drops of blood, that's it. Okay? So that gives you a pretty good idea. Can you see that?
Yes, doctor.
Why don't you get a nice picture? Actually, what I could do is I could do that. It's even better.
Yes, doctor.
And get a nice picture of that for our website, for the new website, so we can show, you know, exactly what's being done. Maybe that's a good picture right there.
Copy that.
Okay. All right. So this is cervical Deuk laser disc repair. Normally a 4mm incision. I did a 5mm. And point is, it's outpatient. There's no fusion being done. It's all repair of the disc. Did you show the video yet? You want to start it?
No, not yet. I'm gonna start the video.
I can't hear anything you're saying. Sanjay?
Yep.
Okay, welcome back. You now have seen why a herniated disc in the neck, also known as a prolapse disc, bulging disc, protruding disc, extruded disc, herniated disc, bulging disc, all of those names for the same thing. The good news is we can fix them all. This is herniation right here. We're at the back of the disc, and these are pieces of herniation. The laser breaks these pieces of herniation up into small pieces, and then they float out through the tube. They disappear. They're not really disappearing, they're actually floating up and out. You just can't see them because they're in small pieces and they're moving very fast. Okay? But we're slowly removing the herniation. Now, just to get an idea of how big this fiber is, this fiber is quite literally 0.5 millimeter wide. So the glass part of the fiber you're seeing is 0.5 millimeters. 0.5 millimeters is very small. And the only reason why we can see it so well is we're using the endoscope, which magnifies everything about 10-fold. Okay? So basically, you're seeing the laser fiber so well, even though it's 0.5 millimeter wide, because we have a endoscope that magnifies everything. There's a little bit of calcium there, but this is all herniation. The blue stuff is the dye that we injected during the discogram. It stains degenerated nucleus pulposus. Nucleus pulposus should not be in this part of the disc. It's supposed to be in the middle of the disc, not the outside of the disc. The only reason it's here is because it's herniated out through the annular tear. It's blue because it's degenerated. Normally the nucleus pulposus is white. The annulus fibrosus is white, the nucleus pulposus is white. Everything is white because the disc does not have much blood supply. It's avascular. And when something doesn't have a blood supply, it looks white in a human body. That's why bone marrow is red, but cortical bone is white. Muscles are very red because they have lots of capillaries and blood vessels. And the disc itself is white, except when you stain it. These are all pieces of herniation, big ones. That's another big piece of herniation. It's about 5 millimeters. Don't touch that. I don't know if she's ready for cervical spine yet. It's a very delicate surgery. He doesn't need to explain. You got to watch and learn. That's how you learn, okay? You learn by watching. Nobody's going to hold your hand and explain things like Sesame Street. That's Sesame Street. You have to kind of watch and learn. Watch every movement of his hand. You should be asking yourself, why is he using his right hand to do that right now? Why did he put that there? Why did he put that right there? Why didn't he put it there? Why didn't he put it there? Why didn't he put it there? He put it exactly there. Why is the blue towel there? You have to study his technique. That's how you learn, not by asking him to explain it. He's busy. You have to use your brain, watch, observe, make inferences from that. But I guarantee you, every little move he makes is for a purpose. Okay? You have to understand the purpose. You have to memorize it, learn it. All right, getting back to our audience, one of my tender teaching moments. So we're working on the herniation. There's lots of little pieces. You can see them here. These are all pieces of herniated disc floating out. And the laser breaks these herniations up into smaller pieces so they can leave through the tube. If we don't break them up into smaller pieces, then the herniation will not come out. It's too big. This is all herniation here. And this is where his symptoms of neck pain and arm symptoms are coming from. You see all the pieces. At least 20 pieces so far.
We have a question from Roscoe on YouTube.
All right, Roscoe.
How can you fix an annular tear before the disc has herniated?
How can you fix an annular tear before the disc is herniated?
Yes.
Roscoe, you asked that question before. The answer is your disc is herniated. You just don't know it. Your radiologist didn't mention it. You don't see it, but I see it. It is herniated. So you're wrong. Your disc is herniated. That's the simple answer. Your doctor missed it. They don't know how to look for a herniation. Good question. Next question. Happens all the time, by the way, Roscoe. You have a herniated disc. They just missed it. They didn't call it a herniated disc. They called it something else. Okay? That's why there's so much confusion among people about what a herniated disc is. Can't have pain from a disc without a herniation. There's no way to have an annular tear without a herniation. I've never seen an annular tear without a herniation. It can exist in theory. The very first step is an annular tear. After that, herniation. I've never seen a person with just an annular tear. They all have herniations. It may be small and your doctor may have missed it. That's the reason why they're not calling it a herniation. They didn't see it. Okay? You need somebody like me who's an expert to see it. I'm not like the other doctors. They're a bunch of idiots, to be honest. That's why people come to us, because we actually make the right diagnosis and we fix their problems. Everybody else in the world just tells you, oh, you have pain, I don't know where it's coming from, you got to live with it. Take pain pills, do physical therapy. None of that stuff works. Okay? If you want to actually get out of pain, you have to go to the source of the pain. To go to the source of the pain, you need somebody like me to help you. That's the truth. You may not want to hear it, but too bad, that's the truth. Deuk Spine Institute, we're not here to have conversations about fake news. We're here to make a diagnosis, what's causing your problem, and then fix it. That's what we do. We're a treatment center. We're not a casual conversation center. So there's lots of problems in healthcare right now. And we can't fix them all. But what we can fix is people's neck pain and back pain. And now we can also fix joint pain, knee pain, hip pain, shoulder pain. We have technology that allows us to do that with minimally invasive procedures. But I can't fix all the mistakes made by other doctors. I can't tell you why they make their mistakes. I can just tell you their mistakes. I'll leave the rest up to you, Roscoe. Any other questions?
We have a follow-up question from Roscoe on YouTube.
Sure.
Then, why do I don't have any radicular pain symptoms? Just axial back pain.
That's because you don't have to have radicular pain symptoms. Your herniated disc is causing your axial back pain. You want to know why? Ask God. Give him ask him to give you an explanation. Nobody's going to be able to explain it to you. It just is. In the end, who cares? What you want is to get out of pain. Right? So that's what we're here for. We're here to get you out of pain. We're not here to ask God why God did things the way God did. I think I told you, Roscoe, to submit your MRI for review in my response to you. Have you done that? Yeah. The best thing you can do, folks, if you're having pain, you want to know why, submit your MRI for review. Get answers. Your other doctors won't give you those answers. They don't know the answers. That's why. We do. All right. Any other questions?
We have a question from Yin Yang Yu.
This is a bone spur, by the way, right here. You see this?
Yes,
I
we do.
just took the bone spur off, okay?
Yes.
People ask me all the time, can you take a bone spur out? Of course. The laser can melt steel, can remove a bone spur easily. Did you find out who makes the tubes, Luis?
Who makes the tube?
Yeah. This tube. Remember I told you, contact the factory, have them make some more.
Oh, this more of this one?
Yeah.
Like the engineers that you're talking about, or the one last time, or no?
Okay, you see this tube?
Yeah,
The engineers didn't make it. They designed it.
yeah.
It was manufactured by another company that we paid the invoice for, remember?
Correct, yeah.
Contact them and tell them we want 10 more,
10 more, you want 10 more? Okay,
Yeah.
perfect, yeah.
right? I think we paid, I don't remember what we paid,
No problem.
but just ask them to give us a quote for 10 more.
No problem, yeah, we'll do it. Yeah.
All right. Sanjay, you have another question or comment?
Yes, we have a question from Yin Yang Yu on YouTube.
All right, very good.
What's the total radiation dosage that a person gets in this hour?
What's the total radiation dosage a person gets for what?
In this hour.
I, yeah, Sanjay, you gotta enunciate a little clearer. I didn't really hear you, but I think you said in an hour.
Yes.
Great question. So we are not radiating this person during the hour. We only use the X-ray machine for a brief period of time. And for normal spine surgery like a fusion, patients will have 5 minutes, 10 minutes of radiation. So 10 minutes. Here they're getting about 1 minute of radiation. So with fusion surgery and artificial discs, they're getting 10 minutes. With the Deuk laser disc repair, they're getting 1 minute on average. So 10 times more radiation with artificial disc and ACDF. Very good question. Yeah, we always. And the other thing is you have to understand older radiation machines, they leak radiation. We have the newest and most advanced machines in the world. They don't leak radiation. But when you go somewhere else, you could be getting a very old machine because the older machines are cheaper to buy. The newer machines are far more expensive. And most places don't want to spend the money on the newer machines, but we do. We spend it because it's a patient safety issue. We want our patients to have the safest surgery possible. So we actually buy the most advanced, newest, best X-ray equipment, and we have a physicist come and monitor it to make sure it's working properly and not exposing the patient or the staff to excessive amounts of radiation. Very good question. Sure. All right, what we're seeing back here at the back of this disc is a lot of scar tissue. You can see that here.
Yes.
The laser is zapping it away nicely.
Yes, we do.
There are bone spurs. Some of them we don't need to remove, some we do. But this is the area of the herniation. And I'm not really seeing a lot of herniation. I'm just seeing scar tissue from chronic inflammation. Why is my laser not going on? What?
It says what?
Fault.
What is?
Which one is that?
Showing right now. This is a 60 actually. Turn it on. Ready? Is ready? Yeah.
It's working. We need to have it
Make
looked
sure
at.
it's,
This is from John,
take a
right?
picture, please.
Take a picture of the screen and text it to Luis. No, it doesn't matter.
Yeah, but
It has to be checked out. Okay? This is a brand new, like refurbished, brand new refurbished machine. All right, Sanjay, have you shown the video on
Cervical.
how the Deuk laser disc repair works?
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months.
levels.
It's when I come off the pedal. All right, welcome back. We are just about done with this case, with this disc. And there's a lot of scar tissue here. Again,
Take a picture. Okay, take a picture and take ready. You ready? Yeah?
uh-huh.
Good?
Grab the next machine, Destiny.
Yeah, it's right there.
You have it here?
Yes, sir.
All right.
So, as soon as we finish over here, switch right away, please. Okay?
I'm almost done. Literally pretty much done right now. So I've gotten all the herniation out. There was a lot of scar tissue in the back of that disc, and that scar tissue came from all the inflammation. Did you guys watch the video?
Yes.
Right, Sanjay?
Yes, we did.
The video shows you how the tear in the back of the disc then lets the herniation out. Once the herniation gets stuck in that tear, then it creates inflammation. Inflammation causes scar tissue. When you see lots of scar tissue like this, you know that the inflammation has been going on for many years. Turns out he's had neck pain for how many years? 14 years. So he probably injured his spine, you know, more than 14 years ago, if I had to guess.
Good, yeah.
All right, let's fire that one up. Guys, we need to plug it in and fire it up. But he doesn't recall the trauma. He doesn't recall an incident. Yeah. Yeah, a lot of patients do not recall a specific incident of trauma. Can you fire it up? So you ask them, what, 14 years ago, what could have happened? They say, I don't remember anything. But, a lot of people played sports like football, and they could have injured their neck during that.
He was very active. He played tennis.
Yeah.
Semi-pro, and he did a lot of those.
All right, we're going to bring our x-ray machine back in. We're going to take a few more pictures. We're going to get this tube docked at the back of the C5-6 disc next. We've already done 6-7. We've just completed C6-7. Next is C5-6. Let's go ahead and get a lateral view. Any questions from our audience?
Yes, we have a question from Raymond on YouTube. How do you know where to make your approach so that you are on target once you are inside anatomy?
So how do I know how to make my approach so I'm on target?
Yes.
Basically, I've done thousands and thousands of disc surgery in the neck. So I have a lot of experience with it. And that experience has taught me the anatomy quite well. And I use my knowledge of the anatomy and my experience of doing spine surgery in the neck for the last 26 years to basically plan my trajectory. So I think plus I use the x-ray machine. The x-ray machine is the most important. If we didn't have the x-ray machine, then I wouldn't know where to go. Shot? All right, very good. 2, 3, 4, 5, 6, 7. So here we go. I'm going to come out of this disc, and I'm going to go up to the next one. Shot? So you can watch me bring the tube out. There we go. Now I'm outside of the disc. I'm sitting on the front of the spine. Shot? Yeah, you can see it. Now I need to check the AP, the front back, to make sure that I'm still in the middle. Quick shot. I'm a little bit to his right side, but not bad. I'm going to move it just the slightest amount to the left. I could feel the anterior longitudinal ligament. Shot. Let me move this out of the way. Shot. All right. so perfect. I'm going to move north. I need to find the next disc. And we call this the Deuk spine slide because it was invented at Deuk Spine by me many years ago when I started doing these surgeries. Okay, I'm off to the side. Too much. I need to go back to the middle shot. Perfect. Now let's get an AP. I'm very happy on the lateral view. We're right over the 5-6 disc. I need to make sure in the front back view I'm in the middle. Perfect. So I'm really in the middle. I could be a little bit to his left. I'm too far to the right. I'm going to correct that right now. I just did. And I should be dead center shot. I'm dead center. Perfect. Now let's go back to the lateral view, and I'm going to hammer this dilator through the front of the disc. Perfect. And you could see we're at 2, 3, 4, 5, 6. Everyone agrees. Shot. And I'm gently tapping. Now I'm spreading the fibers. I'm not cutting anything. This is a spread. Everybody says when you go through the front of the disc, doesn't that cut the disc? No, it doesn't. It spreads it just like putting a pen, a little needle or pen through your clothing. It doesn't damage the clothing. Shot. It actually, shot. All right. It actually just spreads the cotton fibers apart. Remember, inside your body, everything is fibrous. Whether it's muscle fibers or connective tissue fibers, it's all fibers. The skin is not fibers. The skin is a wall, a membrane. You have to cut the skin. Shot? All right. So I've tried injecting. Show us the tear in the back of the disc. You can see it. Show us the herniation. So there's the tear right there. Show us the herniation there. You guys see that?
Yes, we do.
Perfect. Shot? All right. We've got about 15 minutes, doctor, and we'll be done. For those of you who came late, the whole surgery is done through this skinny tube. You guys see that tube?
Yes, we do.
All right. Now, for those of you noticing, I'm holding my hand on the patient's chest. I'm resting my arm. There's a reason for this. You don't want your instruments going in too far. You'll hit the spinal cord, you paralyze the patient. Shot? So I really have to stabilize my whole arm against the front of the patient's chest to make sure that, you know, I've got a nice reference point that I can rely on. Shot? All right, so here we go, sliding down. Remember, there's no cutting, we're just spreading. Shot? Oh, look at that. Look how the dilator shot back, right? You gotta always check your x-ray machine. That's why we have to do the x-ray machine, because the disc is under pressure in this case. Why is the disc under so much pressure? The answer is inflammation. If you've ever seen somebody's knee, when it's inflamed, it's swollen. Lots of fluid, shot? Well, that fluid causes pressure inside the joint, and the disc is a joint. And man, it's under a lot of pressure. So I've got to try to, you don't want to just slide the tube down because then you do a biopsy. Shot? We don't want a biopsy. Shot? I want to slide. All right, that's probably as good as we're going to get it. Let's get the fluoro out. So this disc has a lot of inflammation, pressure, and that's why he's having so much pain. This disc has more pressure than the last disc that we did. This is C5-6. The last herniation we did was C6-7. Notice we've only lost literally 7 drops of blood. 7 drops of blood. Had we done this as an open surgery like an ACDF or laminectomy or artificial disc replacement, we would be losing a lot more blood. The endoscopic laser surgery is the least invasive of all surgeries. And it also is the most bloodless of all surgeries, the least bloody. I know that's not proper English, but okay, I need a pedal. by my foot. All right, any questions? We're ready to get started. Thank you. All right, we're at 20. Yes?
We have a question from
20? Yeah, thank you.
I just want to make sure it's not on the lumbar setting. All right, very good. All right, yes, I'll take the question. You can see all the herniation here and scar tissue and calcium, dystrophic calcification. Yes, Sanjay, I'll take the question.
we have a question from Premier Media Group on YouTube.
Well, 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 my old friend.
What is the history of Deuk Blue?
Of Duke what?
Blue.
Duke Blue. Is he asking about Duke Blue?
Yes.
So you're asking about the,
History of Deuk Blue.
the history of Duke Blue. Uh-huh. Great question. And you're asking the founder. So who better to ask? The history is blue is a beautiful color. It is my favorite color. And, of course, blue is also a color of royalty, which Duke Spine likes to think of themselves as being better than the other guys. But really, blue is the color of the ocean. It's the color of the earth. It's, I think, the most beautiful color. The sky is blue. The ocean is blue. Water is blue. You know, on our earth it is blue. So there it is. Really, it's the color of nature. Obviously, green is another color of nature, but you could always say green is another color of blue, right? So that's why. I think, and then red, in medicine, red is associated with the heart and blood vessels, and there's lots of things that are already red. So we chose blue. We chose blue when we started the company, my wife and I. Yeah, I guess that's it. I just somehow chose it. And I'd say it's been a blessing to have it. That's the story. Yeah, no, at least 10 minutes. All right, great question, and it's good to hear from you, my friend. Hope you're doing well. Back in, I think you're in Arizona, right? I don't know if you guys, you guys may have stuck around in Florida for a while.
I think they said they were staying for a little bit.
Staying for a little bit. Well, shoot, if you're in Florida, come on down.
We have a comment from Bob's On-Site on YouTube.
All right.
Hi, Dr. Duke. I have sent a new patient your way. My sciatica has improved greatly after physical therapy. Diagnosed me with performing syndrome and treating me for such.
Sanjay, we need to enunciate a little bit more. And what I heard was, I have sciatica. It's better. Something about piriformis syndrome?
Yes, it's piriformis syndrome.
They have piriformis syndrome.
Yes.
I see. And so, what are they asking exactly, or are they just commenting?
It's a comment.
Ah, okay, got it. Sorry, I didn't hear a question in there. But that's good to know. Whoever you are, basically, my advice to you would be do a, ooh, look at that herniation that just came out. You guys see that? Remember I told you this disc has more edema, more swelling. That's edema. And you can see why. All the herniations are newer. That is a new herniation at 5-6. That is not an old herniation like we saw at 6-7, where most of 6-7 was older. The C5-6 is newer. Look at all this edematous stuff right here. Pain in the butt for the laser to get rid of. A lot of scar tissue, a lot of torn annulus, very edematous. All right, getting back to you, I would still recommend you do a nice Zoom meeting with me to just get your diagnosis solidified. Guys and gals, we do free Zoom evaluation, MRI review. I do them every Wednesday and Friday currently, and We don't charge you unless you've already had one, and then you have to pay for your second one, but you can't have unlimited. But we do a free evaluation, and I can usually tell you why you're having your symptoms over the Zoom call. I can actually examine you. A lot of people are surprised to know that we can do an exam over the Zoom. But I actually use the patient's own fingers as fingers to touch things. And the nice thing is I can find tender spots, like, you know, the piriformis muscle is usually going to be tender when you have a piriformis syndrome. So I can have my patients over the Zoom touch their piriformis muscle and tell me if it's tender. And that's very helpful in terms of making a diagnosis. So happy to do it for you. No charge. All you got to do is send us your MRI. We don't benefit anyway from these free Zoom things. They're free for you, the patients. You're supposed to benefit. But the thing is that I really do need your MRI images so I can see what's going on. And oh, another herniation. You guys see that come out of there?
Yes, we do.
Oh, yes. That is so cool. Now, that one is probably 6 months old. All right. Now, somebody's going to ask me, how do you know, Dr. Deuk? Well, remember, I've been doing laser surgery, endoscopic surgery now for 17 years. And we've done 1,800 of these surgeries now. So I've seen a lot of herniated discs with the endoscope. And I know what they look like, and I know how old they are based on people's histories. They tell me how long ago their problem started. Mostly they can tell me. So I actually can age these things, and I've gotten really good at it. I'm pretty good at telling you how old these pieces of herniation are based on what they look like here and how they respond to the laser energy. All right. Fun stuff. Questions?
We have a question from Big John on
Big John.
on YouTube.
Welcome back, Big John. We're looking forward to helping you.
Good morning. Can you talk more about the laser? How far past or beyond the tip of the laser tool
Yeah.
does the laser energy travel
Great question.
that you attack the herniation? Is it a millimeter or eighth of an inch?
Yeah, great question. So here's the thing you have to understand. All lasers are different. The laser we're using is a holmium YAG laser. It's a medical laser, FDA approved for this application. Okay? And this is important. Listen carefully. The power output of the laser can be adjusted. Okay? And it's adjusted in terms of joules and hertz. Right, Luis?
Yes, sir.
So there's a burst of energy that comes from this tip, and it's controlled by the machine, which is right over there, and it's as big as a giant suitcase, even bigger. It's like one of those suitcases you see at the airport for people that are like traveling for a month. You know, it's almost like a box. It's all wrapped up in tape. Anyway, they're huge. It's a huge machine, okay? And you go to the control panel and you can adjust the frequency of bursts, which is how fast they burst, and you can adjust the power per burst, okay? And that's what we do. So to know how far past the tip of the fiber the energy is going to go, you've got to know, number one, what kind of laser energy is it? Holmium YAG. Number two, what's the power output per burst and the frequency of the energy, which is 2100, a wavelength of frequency of 2100 hertz is the energy. Then you got to know the actual frequency that I'm releasing that energy, which is, what is it, 20?
Yes.
20 bursts per minute? Is that what it is? 20 bursts a minute. And then you got to know the power output per burst. So there's a lot of variables that will come into play to determine how far past the tip the laser energy will go. But that said, the other thing is it in air? What media is it in? Medium is it in? Medium, okay? And a medium is like the space between the tip of the laser fiber and the target. And In this case, guess what this media is? It's saline. It's basically water. So you've got to know what media it is, know the type of laser, you got to know the frequency of the energy, you've got to know the frequency of the burst, you've got to know the power output per burst, and you got to know the type of fiber. This is a glass fiber. You got to know the quality of the fiber. Like, is this a high quality fiber? Like a high quality glass fiber? They sure charge like it is, right? And then you got to know the shape of the tip, right? That tip right there has a shape to it. And we fracture that tip all the time. And so the shape of the tip is going to influence, you know, how far the energy goes outside of the tip. Does that make sense? So there's a lot of variables. Look at this herniation right here. Scarred down. This is the most perfect demonstration, Sanjay, of how a herniation gets scarred to the annulus fibrosus. And it will not come out unless you hit it with a laser.
Yes, Dr. Deuk.
But to answer your question, Big John, I would say the energy comes out 0.5 millimeter. So about the width of that glass fiber you're seeing is how far out it goes, 0.5 millimeter. It's the standard answer. Is it always that case? Absolutely not. And by the way, I can control this to far more accuracy than 0.5 millimeter by not letting the fiber touch anything. In other words, holding it up in the air. And I can watch the effect of the fiber. I'm watching it. Like right now, I'm on top of that scar tissue right there. I hit it, and it's working, right? And I can see how fast it vaporizes the tissue. And then if I don't like it, it's too fast, I'll pull back a little bit. You know, I'll pull back. So I'll give less energy. Okay, so I'm constantly modulating, I'm not just directing the energy, I'm modulating how much energy leaves the fiber and goes out to destroy and ruin this herniation's day. And the bone spurs. By the way, that is a bone spur right there. See that?
Yes,
That's
we
a
do.
bone spur. Okay, and I took part of it out, but I'm not taking all of it because you don't need to take all of it. There's no point. Taking more of it is just potentially exposing the patient to unnecessary risk. Thank you. God, awesome. Thank you, Nikki. You're not just good looking, you're smart. All right, this is the edge of the herniation. Look at all the scar tissue, okay? And there's a little bit of herniation left, but we're pretty much done. It's just I'm kind of having fun here, but I shouldn't. I just love getting rid of these herniations. I don't know. It's just something like that God stuck in my head is just, it's almost like playing a video game. And I used to play a lot of video games when I was a kid. I love video games. So this is like the best job anybody could ever have, is like, it's like playing a video game in someone's spine against the bad herniations. All right, just about done. I need 2 minutes, 2 minutes. You can see this scar tissue here, maybe a little herniation in it. I'm cleaning it out. This is 5-6. This side looks like it's, so if you talk about the herniation, right? Earlier we saw some fresh ones. That was on the other side. That was on his right side. This side is the left side, and it's really, I don't see any fresh herniations. I just see old ones. So I'm almost done. This is all old scar tissue right here. Old scar tissue. Great questions. I'm going to come and answer more for you. Guys, I've already seen the next patient. I've already signed him. By the way, the next patient is identical to this one. We're doing facets first, Deuk plasma rhizotomy. He's got facet pain. It's on his right side, and it's C3, 4, 4, 5, 5, 6. And then we're going to do the Deuk laser disc repair on his discs, just like we are here. So it's pretty much identical surgery, okay, to this one. 2 cervical cases today. And then the last case for the day is a lumbar. And she's going to be a 3-level lumbar with DPR for the facets. So as you can see, a lot of our patients have facet joint pain on top of their disc problem. So we treat both. They want both treated. And the nice thing is they're traveling from other states, other countries. They don't want to have to come back and do the facets later. So if we can figure out they've got a facet problem up front, then that's great. They can get it done while they're here. Otherwise, they have to come back. All right, that's it. You can see all the scar tissue. That's what's left of it. I don't see any more herniation. I'm happy. We're done.
Sitting on, please. Thank you.
And go ahead and type up your questions. I'll come answer them for you face to face. Sanjay, maybe you can play one of our patient testimonials. Henry just did a great one. A patient from Louisiana. And that guy, I don't know if you have him loaded up, but that's an amazing one. Such a nice story, you know, hearing about how he suffered with pain for so long and now the pain is gone. All right, one last look here at our surgical site. We lost 1/2 milliliter of blood, about 10 drops of blood, the whole surgery. And the whole surgery was done without fusion, without bone, without hospitalization. This patient's going home in 1 hour. He's going to recover maybe an hour and a half. He'll recover for an hour and a half and then he'll go home. When I say home, I mean obviously his hotel, because he's from New York. One more time, just holding a little pressure. I don't think there's any bleeding, but you guys can see. Can you see that?
Yes, we do.
All right. Beautiful. Great job, everyone. Wonderful job. And go ahead and go to one of our testimonials, and I'll come answer your questions. And it's August 2nd, 2023. I'm Dr. Deuk. I'm here with one of my patients from Croatia who is here in a t-shirt and flip-flops.
Florida.
That's
You
right.
gotta look good in Florida.
Looking awesome, feeling awesome. So now you had problems with your neck before surgery yesterday. And why did you come to Deuk Spine Institute?
I had an injury when I was 19. I guess that's 23 years ago. And I've always had chronic pain as a result of a disc problem here in my neck.
Mm-hmm.
And I thought someday I'm going to have to get this fixed. Recently I started getting numbness in the fingers because the disc was pressing on the nerve cord, I guess. And I went to a neurosurgeon in Croatia, and they recommended the vertebrae fusion to protect this area and to solve the problem. And my wife was not satisfied with this recommendation because she had a feeling there was something space age and some new technology out there that could benefit me, and she was certain that this was not right for me. So she went to Google and she Googled the 20 best spinal surgeons in the world, and she read about all of those 20 people listed there, and on there was the Deuk Spinal Institute. I'm not sure where you were in the 20 of the 20.
Probably number one. I'm
yeah, most likely.
But I do want to say, because we are in the space coast of the United States.
Yes, exactly. Yeah, this is where they launched.
This is space age surgery.
This is space age surgery, and I'm so grateful to her because she was certain that this vertebrae fusion was a primitive, old-fashioned operation that we don't need anymore, and she was correct. My first contact with your people was so positive, and I felt really good and encouraged that this is the right thing for me. So we set it up and got a plane ticket, and I flew here to the Space Coast. We're staying on the beach. My mother came down from Pittsburgh. I'm originally from Pittsburgh, but I've lived in Croatia for 20 years. I feel great today. I notice already my neck feels better and the shoulders feel better, so it's still a little sore, but I can tell it's not the same. So I can tell that there's some improvement. I can feel that in my left hand, this numbness is less already. I know that might take a little time to get 100% improvement, but I feel really good about my decision and really great about I would recommend you to anybody else who's suffering any kind of disc problems in the neck.
Well, I used to do the fusions for 20 years. I've done 1,000 patients with fusion.
Wow.
And as a matter of fact, you can watch them on our YouTube channel because I've got hundreds of them. And we do them outpatient, where you go home an hour after surgery. But the difference is with fusion, you're putting metal in your spine, you're losing movement permanently the rest of your life. The metal stays in there. It causes swallowing problems, it causes a voice to change, it causes scar tissue. And then it causes adjacent segment disease, meaning you have to come back again a few years later and do the next disc above and below because they wear out faster once you do a fusion. So all of that is just problematic for patients and it causes ongoing issues. But with the Deuk laser disc repair, you can see we did a 4 millimeter incision on your neck, tiny. And we went through a little tube to the back of your damaged disc where the problem was, pinching the spinal cord, irritating the nerves. And I used a laser to break the herniation up into little pieces and we sucked them all out. I even showed at the end of the surgery on the blue towel, you could see all the little pieces of herniation there that came out from your herniated disc. At the same time, we left the entire front of your disc normal and alone. So you can keep using your normal disc that God gave you.
Wonderful.
Isn't that great?
That's beautiful. What made me a candidate for this instead of the fusion?
Well, everybody that needs a fusion would get the Deuk laser disc repair. Deuk laser disc repair, the endoscopic procedure, could replace all the fusions being done in the United States.
Wow.
From degenerative conditions, but not like fractured dislocations. If you get into a high-speed car accident, your spine is barely hanging on, you want to get a fusion for that. But 96% of spine surgery done in the United States is for degenerative conditions like yours. They would all be perfect for the Deuk laser disc repair.
Well, if I may state my humble opinion, I feel you're doing God's work.
I agree.
So I think that what you're doing is fabulous and wonderful, and I'm grateful that I came here and that you fixed me up.
I
So
thank
for
you,
that.
and I know you're going to be happy with the results. Is there anything else you want to tell your fans out there?
Yeah, just I'm feeling really good, and thank my wife. I gotta give a shout out to my wife. Without her, I would just take what's there, you know. But
Absolutely.
she really did the research and found the best place in the world to get this problem resolved, and I'm grateful to her.
And if you're ever in Croatia, come and visit this guy.
We're very hospitable over there, and we'll have a good time together.
What are you doing in Croatia?
So I'm an executive coach. I teach managers how to manage people.
Oh, wow.
Yeah.
We may need to hire you here.
Yeah, I see your management style, but you know, everything is appropriate to the setting. So because of the high stakes around here, a different management style is appropriate than wouldn't fit in other places as well. So I have been observing your management style, and I quite like it considering the setting we're in. So
I appreciate you saying that because you're very kind with your words.
Yeah.
My management style could definitely get improved. God gave me certain gifts, and patience and management is not one of them.
Yeah, but the stakes around here are high, so we don't need to have a lot of discussion about things.
I can't have mistakes, you know, because they affect the patients and their outcomes, and that's all that matters is great outcomes.
So I respect the way you're running a good ship around here. People are doing a great job. Your people are excellent. So I should also give a shout out to them. So
means a lot to me. Thank you so much.
Thank you, Dr. Deuk.
All right, you take care.
Yep.
Safe travels back
Thank
to
you.
Croatia.
Thank you.
Okay, I hope you enjoyed that testimonial as much as I did. Let's get the camera figured out here. There we go. Sorry about that. And I apologize for my blurriness. Let's see if I can't fix it. Is that better?
Yes, it's better.
A little better. All right. Well, we've just completed a patient's treatment for 2 problems. And it's important to understand that neck pain has 2 primary sources. One is a herniated disc. And if you look at the spine, okay, in the neck, it's quite interesting, but it's got a front to it and it's got a back, okay? We started this patient's journey by going in the back, and I showed you how we used our probe to burn the nerves right here on the lateral masses, and we call that the Deuk plasma rhizotomy because it's a better rhizotomy than you get elsewhere. With other rhizotomies, they use a skinny needle, they try to burn the nerve, they hold it in one place, it doesn't move, and they miss it all the time. But with the Deuk plasma rhizotomy, you can see I was moving it around. Now, we've patented this, we filed a patent for it, so it's going to go through the patent office. We have several claims, so don't try to market it. It's really a Deuk Spine Institute procedure. It's my brain baby, and we've been doing it now for about 1.5 years, and we're developing a tool as well to do it. Okay, so that was the facets. Then our patient had 2 bad discs, and most doctors would have just gone in and they would have cleaned the discs out, and you can see a little cage in there, right? Can you see the cages? Yeah, you can see the cages behind the plate. Those are cages. That's what they put in the disc. They take the whole disc out, they try to get the herniation out behind that, and then they put a metal plate to hold everything together. That's called an ACDF. You can see the metal plate, you can see the screws, right? And you can see the cages behind the plate. Why would you ever want to fuse your spine? You shouldn't. Now we have technology that allows you to basically get the disc fixed without fusion. You just watch the surgery now. I go into the back of the disc where the herniation is, and I use the laser to remove pieces. And the little pieces come out through the tube. It's an amazing procedure. Okay, first question.
We have a question from Raymond on YouTube.
Hello, Raymond. Can I get some coffee, please? Sorry.
My doctor wants to do a T-lift procedure on my L4, L5 with a fusion.
T-lift procedure, L4-5. This is what you're looking at. A cage in between the bones, some bone graft in there, screws and rods.
I've been looking at several
Give
of
me
your
1 second.
videos. Yes.
Keep going.
And have many questions.
Can I get coffee, please?
I've been looking at several of your videos and have many questions. I have submitted my MRI for review.
Wonderful. So, who was that again?
It's Raymond.
Raymond. Yes, Raymond. Raymond. Sounds good. Not Roscoe, but Raymond. Very happy, Raymond. You do not want metal in your back. Once you get the metal put in, my God, it causes problems for the patients. You put metal here, you lose that movement. Your body doesn't know any better. You want to move around and do everything normal. Guess what you do? Well, you're going to wear out the discs above and below. The joints above and below get worn down faster. And there's a name for this. Look it up. It's called adjacent segment disease. Everybody knows about it in the industry, yet we all ignore it and pretend like it doesn't happen. But what it does is it causes those other joints to become very painful. Then you got to go back and have more surgery done. And my God, the surgeons love it. The pain management doctors love it. The hospitals love it. The insurance companies don't really love it, but patients don't love it. But basically, you come in, all these people that make money off these fusion procedures, they love it because you're going back for another fusion, basically. Thank you.
You're very welcome. Let me know if you want me to make fresh, because it
It's
is
perfect.
warm, but
It's perfect. All right, next question.
The next question comes from Charles on YouTube. Good morning, doctor and staff.
Good morning, Charles.
Do you ever go straight to the fusion surgery for disc herniation, or is the DLDR procedure always attempted first?
Yeah. Charles, welcome to our broadcast. There is absolutely no reason to do a fusion on the spine anymore with what's called degenerative spine conditions. What is the most common reason spine surgeons do spine surgery? It's called degenerative disease of the spine. What are the categories of spine conditions that we deal with as spine surgeons? Number one, degenerative spine conditions. 95% of all spine surgery is degenerative spine conditions. Then there's trauma. What is trauma? Trauma is you're in your car doing, 100 miles an hour and you hit something and your spine literally rips apart from the impact. You've got what's called a fracture dislocation. You have an unstable spine. Well, guess what? You've got to have a fusion. There's no alternative. The laser surgery doesn't work for that. Then you've got tumors of the spine. Very rare, thank God. Not many people get tumors, but it happens. If you're having a tumor surgery, we're taking the tumor out of your spine, and we've got to say, we got to drill all this bone away because you got a tumor eating it. You got to clean the tumor out. Then you got to reconstruct the spine with screws, rods, cages, and what are called strut grafts. Okay, you've got all that stuff. You have to have a fusion for that. You have to. Laser surgery won't work. Finally, infection. If you've got really bad infection, like in India, for example, there's a lot of tuberculosis of the spine, and people don't know they have it. It starts eating their spine apart, and literally it'll eat your entire spine. And then you've got no bone left. So you got to go in there and do screws and rods, and you got to fuse it. So let's recap. 5% of spine surgery in the world is in, let's say, the United States, because other third world countries are a little different. 5% of spine surgery in the United States needs to have fusion done. 95% of spine surgery in the United States does not need fusion. The reason why fusions are being done and artificial discs are being done is because it makes more money for the surgeons, for the hospitals, for the companies that sell this junk. Okay, they're making billions of dollars in revenue off of you being the recipient of their good graces. For God's sake, stop. That's what these broadcasts are about. We do these broadcasts to show people there is a better way. It doesn't involve fusion. So no, you don't need to do an ACDF, okay? It's very rare you need to do an ACDF, a PCDF, an artificial disc. I mean, literally, I don't do them anymore. I've completely converted over to endoscopic spine surgery. And by the way, if you go to Korea, that's what's being done. If you go to China, that's what's being done. If you go to India, they're doing it more and more. There's very few fusions being done. It's just the United States. What does that tell you, folks? We're being screwed.
The next question comes from Yin Yang Q on YouTube. Is the C6-C7 harder to reach?
Is C6-C7 harder to reach? Absolutely. C6-C7 is really low in the neck, and the problem we run into as surgeons is you got a collarbone right here. And if the patient's collarbone is kind of high, which everybody's different, by the way, this patient today that we're talking about right now, we just did the surgery, perfect. I wish all my patients had that neck. Oh my gosh, I love it. But the reality is sometimes if you watch enough of our surgeries, you'll see that you can only see down to C4, all right? And then we gotta push down the shoulders. We're pushing the collarbone down. We gotta pull the neck up a little bit, push the shoulders down to kind of get down to C5-6 or C6-7. Today's case was perfect. I wish they were all that way. It'd make my life a lot easier. But the reality is about half of them, maybe a third of them are easy, like this one, and then 2/3 are really hard. We never know until we get in the operating room. So it's impossible for me to tell if somebody's going to be really hard, unless they have a super like no neck Joe kind of person, and I know for sure they're going to have a hard time.
Do you sterilize tubes and use them again, or is the one assigned to each of the patients?
Yes, we sterilize the tubes and we reuse them. They are meant to be sterilized and reused. We clean them. We clean them with a special process that we use for all of our cannulated instruments that have a tube or a hole. And we use the ultrasonic cleaner. We use air to blow through it. We use brushes. We use detergents. We put them in a washer disinfector, and then we put it in a top of the line sterilization unit. So all of the metal that you're seeing is all sterilized and reused.
The next comment is from Kim Kelly Kane on Facebook. He needs advice on his existing conditions.
Sure.
Please bear with me on the comment.
Kelly Kane, Facebook, thanks for making a comment.
I'm looking for a top spine surgeon. Initial trauma to cervical spine, MVA 1982. Trauma again to cervical, 2002 MVA. Additionally, lumbar trauma, L4, L5 bone graft, fusion with respect to instrumentation as result. 2006 MVA trauma, lumbar and cervical again. Lot more coming up. Following my initial lumbar surgery in 2005, I have had issues with the left leg swelling following sitting for short period of time. Would like to have this fixed and have a better quality of life. Any advice? Would like to request consultation.
Sure. And so, what was the name again on Facebook?
Kim Kelly.
Kim Kelly on Facebook. Thanks for posting your comment. Mike, so I was listening to all the motor vehicle accidents and the surgeries happening on your lower back. And to answer your question, definitely we can help your spine issue. No problem. You just need to do a MRI review. We have a free link. It's mri.deukspine.com. Sanjay will type it in right now. And the problem though is your leg swelling concerns me. I don't think that's coming from your spine. Spine problems don't cause leg swelling. So the leg swelling could be either a complication of the spine surgery that you did have at L4-5, where the blood vessels have been compromised and you're not getting enough flow of the blood out of your leg. That's very common, especially if they went through your belly. They probably did some damage to your veins. That's why I don't recommend ALIF surgery, because it's very dangerous. Very dangerous. I would not do it. The other thing that could be happening is if you're getting swelling in your left leg is venous stasis disease, where your valves in your leg in the veins are not closing all the way. They're kind of half closing and blood is pooling. So you need a interventional cardiologist to look at your leg if you're getting swelling in that left leg. You could also have a blood clot in your vein. So there's a lot of reasons, but none of them have to do with the actual spine itself. So I'm happy to help you and guide you, but if you're able to make it into our clinic here in Melbourne, Florida, I'll take a look at your leg and I'll tell you. But you're going to need some tests done, namely ultrasound of the veins in your leg, and there's 2 types of ultrasound. You need one for the blood clot and you need one for the valve. So totally different tests. And you need an interventional cardiologist to check that. So I would recommend going to an interventional cardiologist and having them check the veins, tell them about your swelling.
Next question's from Vitality Approach on YouTube.
Vitality Approach, nice to have you.
When you hit the calcified hernia, it turns yellow. Does this stay yellow forever inside the body as burnt calcium of sorts?
Hey, great question. So you're always asking me challenging questions. So when you saw the laser energy hit the calcium, it turned a golden color. And you're asking, does it stay gold forever? I don't know. What's happening, though, I believe, is what's called oxidation of the calcium. So it's becoming oxidized and it's turning a different color. That's my best guess. I think it's going to stay golden the rest of the patient's life. If I had to make a guess, that's what I would guess.
When you do the discogram on the neck, does patient have to respond to the levels of pain even with the tube close to the neck or vocal cords?
Great question. So one of our viewers, who is it?
Vitality Approach.
Vitality Approach, again, asking if we record a response from the patient during the discogram when we do it on the neck during the surgery. The answer is no, we do not record a response. We're using what's called a chromodiscography rather than evocative discography. If you look up evocative discography, that's the discogram being done to evoke a response to see if the disc is painful. We're not doing that for the neck. The patient is intubated, completely out. They're sleeping. They can't respond. So all I'm doing is a chromodiscogram when I do the cervical spine.
The next question is from Samir M on YouTube.
Hello, Samir M on YouTube. Welcome.
Doctor, I had stem cells in my L5-S1. It's been 5 months, nothing changed. I do have some good days, but the pain is still there. I already shared my MRI. No leg, but back pain from 4 years. I'm only 28. Please help.
Samir, let me tell you, we do not do stem cells in the spine, okay, because they do not work. If the doctor wants to take your money and doesn't care how you do, they will do stem cells in your spine. Stem cells in the spine do not work, period. Period, period, okay? They may work in the knee, they may work in the hip, and we do them in the knee and the hip, but we do not do them in the spine because they don't work. Deuk Spine Institute is ethical. We do not do treatments that don't work. We don't take people's money and provide a treatment that we know will not work. We believe our treatments will work. That's why we do them. We've tried the stem cells in the past in the spine. It never worked. It may give somebody temporary relief, but it's too temporary for the amount of money they're spending, and the benefit is not enough, okay, for the risk. So we don't recommend stem cells. We don't recommend PRP. We do procedures we know will work 100% of the time, and that's why we do what we do. As far as your back goes, send us the MRI. Let me do my Zoom call with you. I'll tell you exactly why you have back pain, and we'll tell you exactly how to get rid of your back pain permanently for the rest of your life.
The next question is from Vitality Approach on YouTube. Do pinched nerves in the neck cause shaky fingers?
So the question is, do pinched nerves in the neck cause shaky fingers? The answer is yes, they can, but there's other causes for shaky fingers. One of them is what's called the central tremor. spelled ESSENTIAL, tremor. Another is movement disorders like Parkinson's disease. And there's also what are called cerebellar tremors, where you can have shaking in your hand due to a cerebellar problem. So typically shaking in the hand is not from a pinched nerve in the neck. It is not from a pinched nerve. It could be from a pinched nerve, but it's unusual. If I took 100 people with a pinched nerve in the neck, maybe 10 of them, 10%, would have shaky fingers. Most commonly, shaky fingers comes from brain issues, not pinched nerves in the neck.
And that's all for the session.
Great. Well, thank you. Great questions. I've enjoyed our time together. The surgery went perfect for this young man. He is from New York. He's going to head home, and I have a feeling he's going to be very happy with his results.